I'm Dr. Richard Isaacson, and on behalf of Medscape, I'm here interviewing someone whose work I've really admired and followed for years now, Dr. Hussein Yassine. He's an associate professor of both medicine and neurology at the University of Southern California, Keck School of Medicine. He's an internist and an endocrinologist by trade, but we somehow tricked him to try to get him to help us figure out the complexities about Alzheimer's and the brain. Hussein, thanks so much for being here today for Medscape.
Thank you. Thank you. My pleasure. I appreciate the invitation.
Yeah. So I saw you speak about 4 or 5 years ago now at the Clinical Trials on Alzheimer's meeting. You had a paper in JAMA Neurology back in like maybe 2016, really showing for among the first times that all omega-3s, whether it's DHA or EPA, omega-3 fatty acids, you may have to kind of not take this one-size-fits-all approach when it comes to do omega-3 fatty acids work, meaning help prevent cognitive decline or Alzheimer's. And not just do they work, but what dose do you need and who they work differently in, whether you have an ApoE4 variant, for example, the most common genetic variant. So maybe take us back a couple of years and give a summary of kind of what some of your research found and why maybe in patients that are at risk for Alzheimer's disease or even patients in the earliest stages, why omega-3 fatty acids may be a really important therapeutic target.
Thank you, Richard. That's a wonderful question. So let's step back a little bit and ask, why are we even interested in omega-3s? Well, there has been a very consistent association between omega-3 levels or intake and the incidence of Alzheimer's disease. And that's not just in the US, but in many different cohorts in Europe as well. So we're talking about large number of cohorts where lower levels of omega-3s are associated with increased risk of Alzheimer's disease. We know that the human body cannot efficiently make omega-3s. We don't have the enzymes to make it, so we have to take it in food. Now, we also know by elegant PET scans that the brain needs a very tiny amount of omega-3s to keep going. This is the adult human brain, unlike the baby brain that needs a lot more. So it needs about 3 milligrams per day, which is a tiny amount. So the question is there a relationship between omega-3 intake that we could use to prevent or stop Alzheimer's disease? And our studies have shown that yes, there is. However, it has to be, as you said, not one size fits all. Not everybody will benefit from supplementation. Our studies suggest that people who do not consume omega-3s are the most likely to get benefit because a lower omega-3 level is associated with brain amyloid plaques. 2, not everybody's going to get Alzheimer's. So we know that about 5 to 6 million Americans have AD. Let's assume you give omega-3s to people who will never get AD. You're not likely going to see an effect because those people are not going to cognitively decline. So who are those people who might get AD and benefit? So over the past 8 years or so, we've done a lot of studies on a genetic risk for AD known as ApoE4. People who carry 1 risk allele have a 4-fold increase, and people who have 2, they have a 12-fold approximately increase in the risk of AD. So we tracked ApoE4 carriers, and our studies suggest that if you catch an ApoE4 carrier early, before they have any disease, we have evidence that the brain is using a lot of omega-3s. This means the brain is pulling those omega-3s from plasma. There is no evidence of cognitive decline. We think this ApoE4 brain is going to run into trouble if the levels of omega-3 in plasma are going to be low. The implications are younger ApoE4 carriers who do not have enough omega-3 intake at a higher risk of developing cognitive decline. So I think, it's not everybody, and it's a specific population. And then finally, should an ApoE4 carrier go and get an omega-3 supplement from the store, and would that be okay? And we just completed a study published in eBiomedicine Lancet showing that 400 milligrams or any doses less than 1 gram that you can find over the counter may probably not do it, because the majority of those omega-3s are getting oxidized in the liver and lost. And the tiny little fraction that goes into the brain is lost when the dose is low. Maybe an over-the-counter dose can help if taken across many years, But if you want short-term effects, short-term could be a couple of years to maybe 3 years, you need higher doses to get those omega-3s into the brain.
So, your work has really elucidated all these super important points. First of all, it's not just about the dose, but it's about which type. There's DHA versus EPA, different types of omega-3 fatty acids. There's different ways to get it. So, as you said, there's supplements that are over the counter. Some of the purities may be terrible. They may have gone rancid. They may not even be, good anymore when you look at the expiration dates. There's FDA-approved omega-3 fatty acids available by prescription. They're the same omega-3s, but only they're regulated, and they've been studied, in this case, cardiovascular disease trials. But you brought up so many good points. When a practitioner like me is on the front lines and seeing a person, and they say, "Doc, what can I do is there anything I can do to reduce my Alzheimer's risk?" My usual answer is say, well, yeah, there's a lot of things you can do. We may not be able to prevent it entirely, but if we can delay it by a few years, and then the blockbuster drug comes, well, then guess what? By doing these different things, you've delayed or prevented your own Alzheimer's. And honestly, omega-3 fatty acids, I believe, just have to be part of this conversation. Also, you mentioned not everyone's going to get Alzheimer's. Also, not everyone needs omega-3 fatty acids. And doing blood analysis, we do an RBC, red blood cell level. RBC levels of omega-3s are really important. If they're low, those people really need to be replaced. So from a practical clinical perspective, I think physicians out there need to take a step back and say, wow, there's been an explosion of evidence. What I read 10 years ago when we tried omega-3s in randomized trials for treating Alzheimer's disease, those trials failed. Okay, well, maybe they're not going to work because of dose, whatever. And maybe when they already have dementia, they're not going to work. But for prevention and risk reduction, I think it's honestly one of the most important. We have exercise, we have nutrition changes, we have blood pressure control, sleep modification, stress reduction. But omega-3 fatty acids, I think, really needs to be prioritized in the conversation.
Sure. Thank you, Richard. I mean, these are great remarks, but I do have to maybe usher some caution.
Yeah.
I would personally say that yes, I am convinced that having seafood such as fatty fish and salmon once a week may make a difference based on large good quality epidemiology studies that may not be replicated by short-term clinical trials.
Right.
But I think when it comes to supplements, we do have to take this with a little bit of caution because, yes, we have some signals that it may work in prevention in certain populations, but we still haven't nailed that down. And we still need to do more research to give a supplement the same recommendation that we give to a statin or to an aspirin or to any well-researched medication in the setting of a clinical trial for a clinical recommendation. So supplements, as you mentioned, they're all diverse. Some of them are rancid, some of them are great, and we don't exactly know what dose, we don't know exactly how long, and what are the efficacy biomarkers. You mentioned RBC-DHA, but does increasing the RBC-DHA translate into lower cognitive decline? It's a great question. We don't have the answer to that yet.
Right.
So I think the answer is not to throw omega-3 into the bin, but rather do more research to figure this out. Because there is really good signals that need to be refined in just better trials. Yeah. Not one size fits all, but more tailored into specific population.
Yeah, so I couldn't agree with you more, and I agree. We have to be cautiously optimistic. More research is definitely needed, and getting omega-3s from fatty fish, wild salmon, better than farm-raised likely, mackerel, albacore tuna, sardines. Man, you almost can't eat enough sardines. They're very brain healthy. There's lots of different types of fatty fish out there, and then either through a prescription or potentially through a supplement, this has to be a one-on-one discussion with a physician and the patient. And I agree with you. We need to track outcomes. In our clinic, we track cognitive trajectory every 6 months. We track red blood cell DHA. We track cholesterol markers. We track advanced cardiovascular markers that omega-3s are actually a treatment, an FDA-approved treatment for high cholesterol. So I think these are really key. I wanted to wrap up with one question. When it comes to no one size fits all, the term pharmacogenomics and nutrigenomics underscores the importance that certain people with certain genes may respond to something, and other people with different genes, they need a different plan. They're not going to respond the same way. When it comes to the ApoE4 variant, whether a person has one copy or one ApoE4 variant versus two ApoE4 variants, if there's someone out there, a practitioner, that wants to try to help a patient and the person has been genetically tested either through a commercial lab or through whatever way to get it tested, how do you think about the dose, the duration that someone needs to take it for someone who has an ApoE4 one variant versus two versus no copies?
Right, it's a great question again. And whatever I'm going to say is not based on strong clinical evidence, and we need to do more trials.
Yeah.
But here is my suggestion. Having two copies means you're going to get severe disease at a younger age. Yeah. The implications to that means interventions have to be much earlier than having one copy. Yeah. So a homozygote should probably start at, maybe in the 20s or 30s with lifestyle interventions, whether it's going to be exercise, whether it's going to be eating seafood. You don't have to eat a lot of seafood to get omega-3s. Once a week would probably be enough if you have a good sized piece of salmon. Mm-hmm. So all the preventive measures we're talking about should be more aggressive, higher dose, earlier in homozygotes compared to heterozygotes, who actually may have a more window of time before they get the disease. And in addition, you have to take into consideration family history. So having a family history in addition to ApoE4 increases the risk of cognitive decline because not all heterozygotes will get AD. In fact, the majority of heterozygotes may not get dementia. 25% of the population carry one E4 copy. So again, having two copies means we have to start early.
Great. Hussein, that was awesome. Thank you so much. I've been an admirer of your work, and I really appreciate you taking the time to educate the folks on Medscape.
I appreciate that. Thank you, Richard.
Thanks.